Welcome to this Adolescent Health meeting at ISEH, our first talk of 2023. I'm Dr. Sarah Davies and I'll be your host for the evening. By way of introduction, I'm a consultant in sport, dance and exercise medicine at ISEH, Chiswick and Chelsea, and CMO at the Royal Ballet Company and School at the Opera House in London. As I've experienced from my current position as CMO at the Royal Ballet School and my prior position as CMO in track and field development athletes, the holistic needs of young people are huge as they develop physical skills and other attributes, underpinning choices for physical performance and lifelong behaviours. The idea for today's meeting started from a working group to support the growing needs, if you'll pardon the pun, of the young developing population to support physical activity participation, fitness and health. We wanted to bring together expert knowledge in this topic, and the idea of a webinar for adolescent health with a holistic vantage has had a sign up of nearly 900 attendees, which is a fantastic turnout and a new high for ISEH. So thank you for turning up. We have a splendid lineup of guest speakers for you tonight with specialist expertise in the area of adolescent health. First up, Dr. Robin Chatterjee, who is a consultant in SEM at ISEH, Chiswick and Chelsea, and he'll give us a short presentation today on the role of sport medicine in the health of the adolescent. He specialises in traditional and cutting-edge techniques to investigate pain of unknown causes. He is the General Secretary of the British Association of Sport and Exercise Medicine, BASM, and has won awards for his research into medical causes of low back pain, just one of a number of his articles on musculoskeletal health.
Hi, my name's Dr. Robin Chatterjee. I'm a consultant in sport and exercise medicine, and I work at the Institute of Sport and Exercise and Health. And today we're talking about the role of sports medicine in the healthcare pathway of the adolescent population. So first of all, ISEH is a centre where there are many sports and exercise medicine consultants and neurologists and cardiologists and physiotherapists and lots of other clinicians that I'll talk about in a minute. And we all have a background in either working with the paediatric population, so in schools or in sports academies or dance academies or in the NHS or private practice. And these are some of the places that I've previously had experience in. And personally, I've worked in the UK and Australia and have qualified as both an anaesthetist, so somebody who deals in pain of unknown cause and chronic pain, in general practice as well, and then sport and exercise medicine after that. And ISEH is part of the HCA organisation, and therefore we have sister hospitals and clinics all over London, and I work in Chiswick and Chelsea as well. Apart from that, we have clinics in the Shard at London Bridge, at the Princess Grace, which is in Marylebone, the Wellington Hospital in St John's Wood, and a clinic in Elstree. So what is sports medicine, and why should you refer your adolescent patients to us or your children to us? So we are specialists in the non-surgical management of soft tissue issues. So we look at the root cause of why one may have a bone, joint or muscle pain. So we look at the roles of sleep, stress, nutrition, hormones, mental health, gynecology, physical activity, posture and medication, and we see how that may affect or cause one's pain or inability or restriction in moving a joint. We offer a point of care ultrasound scan, which is where we take a scan at the first consultation in clinic, and there are several procedures and other investigations that we can offer as well. So the sort of conditions that we see generally are any kind of bone, joint or muscle pain of unknown cause. Some non-surgical musculoskeletal pains and conditions that we see include low back pains, heel pains such as plantar fasciitis, ligament problems or tendon problems. Naturally, we see sports injuries, dance and performing arts injuries, and also problems caused by either certain sports or activities at school that may result in repetitive strain injuries. Nowadays, obesity is an issue in children, and we can help with that. And we also deal with musculoskeletal or exercise problems and issues in young girls, and also in those with illnesses such as diabetes or asthma. Now, the specific child or pediatric issues that we see are essentially can be grouped into overuse injuries or overload issues. So overuse injuries are, for example, injuries where we have issues with tendons. So that's when tendons, which are elastic band type structures attached to muscles. So when they're pulling on bones, one can get a apophyseal injury. Then as children are growing, they may have issues with their growth plates or indeed the growing bones. There may be bone stress injuries. So that's when there's load or pressure on a bone or repeated activity causing issues. And then there may be problems within the joint or the cartilage, so osteochondral injuries. Now, bone stress injuries are actually a type of overload issue, and some children have movement dysfunction. So that's when the biomechanics of the body cause an excess load or pressure to go through a joint, causing pain, such as patellofemoral pain syndrome, which is where you have pain in the knee. Now, the kind of services or treatments that we offer include specialist clinical examinations of bones, muscles, tendons, ligaments, and joints, and these are done by our expert clinicians. We also offer a point of care diagnostic ultrasound scan. So that's when we actually scan the patient at the first consultation and go through the imaging whilst the patient's there. We offer a variety of injections, such as steroids, which are also known as cortisone. We can offer anesthetics, which are pain-killing injections, PRP, which is platelet-rich plasma, and that is a new sort of regenerative form of medicine, where if somebody has a tendon problem or wear and tear in a joint and it's been going on for a long time and nothing seems to be helping it, then this is a modern new way of treating that. And we have other injections as well that we could offer, such as viscosupplementation, which is an injection of lubrication into a joint. Now, apart from all these injections, we offer specialist investigations such as MRI scans, CT scans, and bone density scans as well. In addition to that, we offer blood tests and something called shockwave therapy, which is, despite its name, it's use of ultrasound waves to try and treat tendonitis, so thick and swollen tendons. We work in teams, in multidisciplinary teams, where we can formulate rehab plans together with all our colleagues, such as physiotherapists, podiatrists, and other kinds of therapists. We offer advice on nutrition, vitamins, minerals, and dietary intake, as well as specific exercise prescription plans and weight management plans for individual patients. Now, you can see the clinic setting is much the same as one would find anywhere. So, we can have a great face-to-face chat or a virtual consultation if that's preferred. As I said before, we have an ultrasound machine in the room where we can scan the patient in real time and explain the conditions that we're seeing as we're scanning. There's MRI and CT available for further investigations if needed, and this is the PRP. So this is where we take blood from a patient, split it into its different components, and then inject the platelets back into the affected joint in order to treat it. And shockwave therapy, despite its harsh sounding name, is a non-invasive way of treating tendonitis. So other clinical services available at ISEH to help the adolescent population include our brain health clinic, our concussion clinic. We've got a health and fitness assessment pathway, a long COVID pathway, dance injury clinic, performance reconditioning, physiotherapy, cardiology, nutrition, podiatry, psychology, a respiratory clinic, and a tendon clinic. But all in all, we have a well-rounded, holistic approach to treating the adolescent or the pediatric patient. This is a picture of something called cardiopulmonary exercise testing, and this is when we get the patient running and have a bunch of leads and wires attached to them, so we can monitor how the heart and the lungs are working in relation to the amount of activity being exerted by the patient. And we also do sports performance assessments and physical capacity evaluations. So that's when we look at muscle strength, strength distribution, biomechanics, gait analysis, and how all these different issues cause muscle, joint, or bone aches and pains. So that's a whistle-stop tour as to what is sports medicine, how we can help the adolescent patient, and how ISEH in particular can help. Thank you very much for listening to me today.
Thank you, Robin, for a superb insight into the role of sport medicine to support the health of the adolescent. So I have a few questions that have come in via the Slido mechanism. So the first one is, how often is hypermobility considered in exercise training and injury prevention? Is enough being done?
Thanks for that question, Sarah, and whoever asked it out there in the internet sphere. So hypermobility is considered in every patient. So every child, every adolescent is treated as an individual, and often we don't know why they're coming in. And one of the things that we'd look for is hypermobility, and that would determine how we investigate the issues and our onward management plan. In the clinic setting, initially we would do a Baton score for everyone, and that's a score to look for hypermobility, or to see, to assess how hypermobile one may be. Sometimes the Brighton criteria would be needed if we're suspecting Ehlers-Danlos or some other sort of hypermobile issue. Now, generally in the adolescent person, there often is more hypermobility than in adults, and obviously that needs to be factored into in how we would treat the patient. I think the key would be a multidisciplinary team approach where we discuss the various issues in management, and that would be discussions with physiotherapists, with sports therapists, strength and conditioning coaches, podiatrists, nutritionists, and other clinicians as well. It's difficult to have a sort of blanket answer for this because, again, the degree of hypermobility will vary from person to person. But to summarize, yes, it is important and it is something that we consider.
Fantastic, thank you for that. So another question, what COVID safe protections do you have in place in the clinic? For example, ventilation, especially for CPEX testing and so on.
Sure. Yes, obviously we're, I'm not going to say COVID proof, but we try and protect against COVID as much as possible. Patients are given a questionnaire before attending the clinic asking if they've had any of the signs and symptoms of COVID recently. They're asked about if they've had the vaccination. Then there's hand washing availability everywhere in the clinic. There's good ventilation so that when the individual is doing CPET testing, that there isn't stale atmosphere, and that we're trying to reduce the risks of germs as much as possible. And then obviously things like wearing gloves, masks when appropriate, cleaning skin if doing an injection, for example, all the usual hygiene protocols that have been in place since COVID began.
Fantastic. From what age would you give a steroid injection in an adolescent? When would you start thinking that it might be appropriate to do that, or would there be any contraindications there?
So with steroids, we would administer a steroid under ultrasound guidance if there was evidence of inflammation and if it was necessary to reduce the inflammation. There's a number of risks and side effects with steroids that one has to consider, and this is discussed with the patient before it's administered. So we would talk about things like the patient's diabetic profile, risks of menstrual disturbance, then things like tendon damage, infection, allergic reactions, anaphylaxis, etc. With regards at what age can we administer a steroid, again, it all depends on the appropriateness. The dose of the steroid varies per weight, so it's dosed in milligrams per kilogram. So it's not that as though you can actually overdose somebody, but you need to give the appropriate dose. But more importantly, I think it should be determined if the individual needs a steroid at all in the first place. So why do they have this inflammation? And is it possible to alleviate it through more conservative means? Or, you know, is a steroid actually absolutely necessary?
Great, and I think we'll have to leave it there for you. Thank you very much for what has been an incredible insight into the role of sport medicine to support the adolescent health. Thank you very much. So moving on.
Thank you for having me.
Our next talk is being given by Dr. Ajai Seth, who is a consultant in SEM at London Bridge Hospital. And he's presenting on common upper limb injuries and problems in adolescents. He is Chief Medical Officer for Team GB Wheelchair Tennis and is a senior lecturer in sports medicine at King's College Hospital, where he lectures on all aspects of sport medicine and science. Over to you, Ajai.
Hi there, my name's Dr. Ajai Seth, and today we're going to be talking about common upper limb problems in adolescent sports medicine. So what we'll briefly cover is history taking, the key points we need to ask from our patients, some functional and developmental anatomy. We'll work through different body parts, starting at the chest and working our way down. We'll talk about the key considerations in adolescent sports in general and different management strategies. So with any history taking, the mechanism of injury is really, really important when you're trying to find out what happened to your patient and how they got injured. So with the upper limb, as with any other area of the body, there's lots of different ways you can get injured. Understanding the sporting technique is really important. So ideally getting some video footage of how they perform their golf swing or tennis stroke is ideal, because often what they're describing is very different to what you will see them doing. Load and volume, very important to understand what's going on there in terms of, has there been any recent changes, and common things, you know, we often really want to focus on are, has there been any recent coaching change or technical change or equipment change that's led to the injury essentially. One key thing I always really try and focus on is the academic and parental demands on adolescents. So often, you know, they'll be going through stages of their academic life or schooling that there's a lot of pressure on them to perform. A classic example is, you know, going for a sports scholarship, for example, and there's a lot of intensity on them to perform a certain way. So it's trying to understand what their social history is. Also about their growth and development. So sometimes they'll be growing and they'll be going through a peak height velocity or growth spurt, and that's a key time of their adolescent years where they can get injured. Just to remember, like any other part of the body, lots of things that can get injured, from, you know, bony, ligamentous structures, nerves, muscles, and that has a real indication on how quickly the injury recovers and what type of rehabilitation they need. So just important to consider all those anatomical things. So we'll start off in the chest. So sternoclavicular injuries, some people may not be overly familiar with them, but essentially the clavicle is an interesting bone because it's the first bone to begin ossification, but it's the last bone to fully fuse. So both ends of the clavicle don't really fuse until the early 20s. And if you've got usually quite a significant force going onto the clavicle, either from a forward to back or back to forward motion that can put force on the sternoclavicular joint. And often patients are presenting with a pop that's felt in that area. There can be tenderness. But what we really want to look out for is posterior displacement of the clavicle, which therefore can potentially go into the mediastinum. And that's something that requires like a full cardiovascular workup and assessment, and obviously urgent intervention if there is a suspecting posterior displacement. So in these images here on the X-ray at the top, you can see the arrows pointing to a mid-clavicular growth plate injury from a fracture, which you can quite clearly see on X-ray, and from a CT scan below, you can see there's actually been displacement of the clavicle in another patient, that is, and you can see it's almost compressing on the great vessels behind. So clavicular injuries itself, again, the clavicle is a very fascinating bone because it undergoes two types of ossification, intramembranous and endochondral. So intramembranous is the one that occurs in flat bones in general, and endochondral is the one that occurs in long bones. Usually there's a bit of force involved, so like RTA. Very interestingly, it's 8 to 15% of all pediatric fractures, but half of those occur under 7. So usually there's significant force going through the clavicle in the adolescent years. So I normally see it on the rugby pitch, or I've actually had a few go-karting injuries, for example, that have had clavicular injuries. 80% of them will occur in the middle third, so the green area. Then the lateral third and the medial third is the less common. Often they heal very well, and if you ever wondered why they look so horrific on X-rays, it's because there's lots of different muscles pulling the fragments in either way. So what usually happens is the proximal fragment goes up and the distal fragment goes down. And yeah, they heal very well in slings, but if there's lots of displacements or they're shortened, then yeah, surgical opinion is certainly warranted. ACJ injuries, so often, we're much more familiar with these, but the difference in adolescent patients is that the clavicle sits in a periosteal sleeve, which is essentially a thin film of tissue. So what may look like a ACJ dislocation actually is a metaphyseal injury or fracture, and you get displacement from them. The mechanism is very similar, so you can get a direct blow onto the point of the shoulder or fall onto the outstretched hand. They can present with bruising, deformity, mechanical symptoms, and the classic scarf test is usually positive. Again, do very well with conservative management regarding on the amount of displacement they have. You may be familiar with Rockwood classification. That's also applicable to pediatric cases, but there's a special pediatric classification in there. So just have a look out for that. You also may have heard of this term of osteolysis. So osteolysis essentially is a lateral clavicular growth plate injury. And I tend to see this in patients who are getting into the gym, doing lots more lifting, lots more overhead press, snatching, cleaning and jerks, that sort of stuff. So they're, into the weightlifting era. And essentially what you get is this sort of fraying of the distal clavicle, and that can be quite painful and quite irritative. So again, it's the management really is about understanding their loading, understanding how they're lifting, getting a lifting coach to look at their technique. Some people have different ranges in their shoulder, and they may not be able to achieve those types of ranges. Sometimes you can benefit from a corticosteroid injection to the joint to try and settle it down. ACJ resection is rarely done in adolescent years, but again, more common in adults. So another interesting anatomical part of the body is the proximal humerus. So essentially the humerus starts in lots of different growth plate centers. And by the age of 7, usually, but certainly by the age of 10, the proximal humerus will form a single epiphyseal center and one physeal plate. And this plate is very important because it accounts for like 80% of the growth of the entire bone. And yeah, a lot of proximal humeral fractures actually peak in the adolescent years, and you can essentially get two types. You can get metaphyseal fractures, which are generally more common pre-adolescence, or you can get epiphyseal separation, or the classical Salter-Harris type fractures, particularly 1 and 2. The diagrams on the left show that. So on the X-ray on the left now, you can see a metaphyseal fracture. And on the X-ray on the right, you can see a bit of widening of the proximal physeal growth plate. So very important to consider that in adolescent years. You also may have heard of little leaguer's shoulder. So that is essentially a stress injury. And this is actually much more common of what I see in a sports medicine clinic, because it's all to do with repetitive microtrauma with large rotational torques typically involved in throwing sports. And so essentially you get stress across the physeal plate of the proximal humerus, and it's most common seen in athletes between the ages of 11 and 13. You have to look at the throwing mechanics to understand where the forces are the most. And MRI is really, really useful at detecting these types of injuries. So management, again, it's about rest and restricting their play or restricting their throwing or number of throws, all about load management and scheduling, estimating their peak height velocity. And they can do other things, while they're resting. They can work on hand-eye coordination, cuff strength, other attributes, lower limb strength, that kind of thing. So just very briefly, we'll just have a look at, apophyseal injuries or growth plate injuries in general, generally more common during adolescent years. Very important to determine the peak height velocity and plan for it. So you might want to plan competitions or training. Also to do with their training programs and understanding which athletes they're competing with, and is it age appropriate or ability appropriate or size appropriate, and that concept is called biobanding. And strength and conditioning, very, very important to make sure you're supporting the joints with the appropriate muscular and endurance, as well as the flexibility of the muscles as well. So anyone who's done pediatric A&E will remember this. It's the ossification centers of the elbow. But actually in adolescent years, what is more important is the age that these fuse. And as you can see on the right-hand column there, there's a huge variety in different ages that these fuse. So it's very difficult to tell what is an ossification center and actually what is an avulsion injury. Again, in the adolescent years, the green boxes are highlighting what are the most important fractures. So 80% of pediatric elbow injuries occur at the medial epicondylar apophyseal plate, and that peaks around the age of 10. And that's actually the most common thing we often see. You also get the traumatic injuries like radial head fractures, elbow dislocations, which can also occur in adolescent years, but again, usually trauma related. So the throwing adolescent elbow is again, like the upper limb, very, very important in that there's different forces going through the medial aspect and the lateral aspect. So in the medial aspect, you tend to get more of a distraction, and on the lateral aspect, you get more of a compression. And that brings us to two different types of conditions. Where on the the medial aspect, you'll get little leaguer's elbow, where the MCL ligament is pulling on the medial apophyseal plate, and the X-ray at above here can show there's just a bit of widening. On the left here shows a bit of widening of the plate. Where on the radial side, you often get the radial head abutting the capitellum, so that can produce a little of cartilage debris, which we call osteochondritis dissecans. The top left graph here is very interesting because it actually shows how similar the forces going through the elbow are to the shoulder, and that can be quite high. So you can reach up to, in adolescence, you can reach up to usual Newton meter torques of 40, 50, but in professional sports people, you can even go into the 200-300s, which is a significant force going through these tiny ligaments in the elbow and the shoulder. So we have to mention the wrist. So the distal radial metaphyseal fracture is the most common fracture of childhood, and very important because, like the humerus, the distal radius actually contributes to a lot of the length that the arm will eventually have, and we worry about growth arrest from that point of view. So yeah, you often commonly get non-displaced fractures, but with more higher force transmission, fall onto outstretched hand or some form of impact, you can get displacement of the fragment. And how you would manage these all depends on the amount of displacement and the degree of angulation, which we'll have a look at in a second. But also you have to consider if there's been significant enough force to displace the fragments, are there issues anywhere else, fractures higher up or lower up in the wrist or even in the sternum or higher up in the chest. And these are just a few of the examples below of different types of fractures that can occur associated with distal radial fractures. So in terms of angulation, the general principles are, as the child gets older, you want the fracture to be less angulated. So you're less willing to you want at least less than 10 degrees of AP angulation, and dorsal angulation also less than 10. In terms of the apposition of the ends, which we call bayoneting, you want them to be really aligned. You're not going to give, when children are below the age of 10, you might allow for a little bit of poor apposition, but in the adolescents, that's unacceptable. You have to get it aligned. So often need a prompt orthopedic review, particularly with open fractures, and obviously assessing the neurovascular status is really important. So talking about wrist plate, growth plate fractures now, so not the metaphysis, but the growth plate. Again, Salter-Harris can classify this for us. Type 1 and 2 are really more common, but actually, fortunately, not often associated with growth disturbance, whereas type 3 and 4 are quite rare, but they are associated with growth plate disturbance. Type 5, interestingly, is more of the compression element of the growth plate, and you don't really see that in adolescents until they've had growth arrest and issues there later. We'll just briefly touch on growth stress injury, and actually, like the proximal humerus, you can often get growth plate injuries that can cause growth wrist arrest. So it's the same principles. I often see this in divers or gymnasts who have repetitive compression on the wrist. So it's important to understand the sport that they're doing and why the distal radial growth plate might be injured. We'll just briefly touch on the dreaded scaphoid fracture. Again, in younger children, it doesn't ossify at all, but in adolescents, they have this retrograde blood supply. So again, you're worrying more about proximal pole fractures and waist fractures. And again, you're getting surgical opinion as required. So here you can see a non-union of a scaphoid fracture that hasn't healed. Last slide is just to make sure we look at the red flags always. So tumors, infections, or non-accidental injury, making sure we've considered all these things, particularly in adolescence years where they've got different pressures and social pressures going on them. So it's very important to just have you always thought about these other factors that may be happening? Have you got the appropriate imaging? Have you considered red flags? Lastly, always important to keep a very holistic opinion. There's lots of issues going on in adolescent sports medicine, particularly from the more social and performance pressures. So make sure you've covered all those factors. So thank you very much. Feel free to get in contact with me. My contact details are here. More than happy to answer any questions. And if you want to come down to clinic at any point at ISEH, you're also more than welcome to. Thank you.
Thank you, Dr. Ajai, for an insightful dive into upper limb injuries in adolescents. So a few questions have come through for you. So first one is, do you have any concerns with teenagers trying to lift heavy weights on a regular basis? Very interesting question.
That is a good question, because I think the first question is, how do you define heavy? But it is a general principle. Weightlifting in adolescence is absolutely fine as long as it's done with appropriate form, appropriate technique, and under appropriate guidance. And actually, it can be a really, really useful adjunct to training. So often you'll have adolescents who do a lot of training, a lot of sports like, for example, football, but it could be really well accompanied if they added in a strength program. I think there used to be old rhetoric around, oh, you shouldn't lift weights until you're an adult or until your older years, but actually you can start strength training and learning more about the form of how to lift weights and how to lift sensibly from a very young age. So it's not uncommon now for 8-year-olds plus to be in the gym and start moving and start lifting weights, and it helps proprioception, it helps develop muscle conditioning, it helps with a lot of other factors, and just really does balance training. So I would encourage all adolescents I see to really understand the principles of strength and conditioning training and actually get trained on it and begin to use them in their own training plans.
Fantastic, thank you. So a case study for you from a participant. They say, I'm treating a sporty 16-year-old with anterior recurrent subluxation of the sternoclavicular joint, SCJ, in the dominant arm. It's an atraumatic injury. So what are your thoughts as to the long-term prognosis and management in a case like this? It's obviously not, you know, a lot of information, but what can you tell us?
So I think the first thing to say about that case is that it's actually quite common. And I know in the previous talk, we were talking about hypermobility and just general joint pliancy in adolescents. So it's not uncommon to get mobile segments, whether it's the sternoclavicular joint or whether it's, you know, the elbow, the shoulder joint in general. I would say, linking into what we were just talking about, strength and conditioning training, the vast majority of times they're not going to have a strong enough upper girdle to support the sternoclavicular joint, and by that I mean pectoral muscles, the shoulder girdle, the scapula itself. So it's about really tightening up the complex, what I like to call the thoracic ring. So making sure all components of the musculature around the thoracic ring are really steady. And you often find that as patients grow, a lot of these symptoms kind of settle down. So, I mean, slightly different if it was, like we said, posterior subluxation or posterior dislocations, but anterior subluxations is really common, particularly in the dominant side as well. If they're playing racket sports with the right hand, again, you might want to just see how much they're playing. If they're playing, 20 hours of tennis a week, you might say, actually, that's probably a bit too much, and just modify it from that point of view. But yeah, very common example, and something, if you take a more holistic approach, it's not actually about the sternoclavicular joint, it's more about just their training and their general lifestyle as well.
So pacing and load management through the upper limb, the shoulder, the sternoclavicular joint, and the scapulothoracic aspect of the shoulder is really important as well, wouldn't you say?
Yeah, and we're so used to talking about lower limbs in terms of kinetic chains, and we all know that from running and gait analysis and gait assessment, but the upper limb's the same. So from particularly with non-impact injuries, from the point of contact, whether it's a racket or club sports, force gets transmitted up the body, and also you are creating force from the trunk down as well. So it's about identifying what are the weakest links in that chain, trying to strengthen other areas, and again, load management, as you say, Sarah, technique, all these things are actually more important than the structures themselves. So yeah, if you can usually counsel patients correctly and get them on a balanced program with the right training in place, then 9 times out of 10 you've solved the problem.
And how do you find that neck injuries interplay with upper limb injuries?
Again, so there is a cohort of patients who suffer with a condition called thoracic outlet symptoms. So that's essentially where a lot of structures are tight in the neck, and muscular structures can be tight in the neck, or for other reasons. But that can interplay as well. So, of course, the upper girdle neck assessment is always key, and making sure the neurovascular status of the arm is has been considered as well.
Fabulous. Well, thank you very much. I think your time has run out now, so thanks for a fantastic insight into upper limb injuries in the adolescent. So we're moving on now to Dr. Amal Hassan. There's been a slight change to the schedule, so apologies if that upsets the apple cart, but we've got Dr. Amal Hassan here, who's ready to speak, and she is a consultant in sport and exercise medicine at ISEH. She's presenting on a very interesting topic, fueling the adolescent during the growing years. And with her strong experience in seeing young developing dancers at the Royal Ballet School, she is particularly well placed to speak on how to manage energy intake, exercise, and recovery in the adolescent population. So over to you, Amal.
Hi, my name is Amal. I am going to talk to you about the importance of fueling the system, managing energy intake, exercise, and recovery, all whilst growing. And I'm pleased to speak to you about this topic because it is a lot of what I see both in clinic at the ICH, seeing adolescent athletes, but also at the Royal Ballet Lower School, week in, week out. So adolescence is a time characterized by rapid and transformative development, during which young athletes will need available energy to fuel these demands alongside those of any exercise-based activity. They're developing physically and physiologically, as demonstrated by the adolescent growth spurt and by sexual or somatic maturation, cognitively, and they're balancing those daily demands at school, in academic assessment, homework, alongside emotional development, developing a sense of identity, of self-esteem and resilience whilst navigating peer influences and dynamics and even sexual identity, and also behaviourally, working out the do's and don'ts of risk-taking and beginning to form lifelong behaviours, including those that support lifelong physical activity participation. Now, Gallant et al. Last year demonstrated 5 distinct sport participation profiles in childhood and adolescence. And it's most likely that if you're tuning in tonight, that you will either know or be working with adolescents who are either engaging in a single sport at high frequency, or those who are involved in numerous sporting activities throughout the week, in both cases possibly recreationally and competitively in and out of school. Of course, the latter profile of multi-sport participation has been demonstrated to favour continued engagement in physical activity and sport for life, as well as favouring athletic development for a successful sporting career. So, in order to benefit from all of the positive aspects afforded by adolescent sport participation, avoiding an energy deficit by balancing a busy week of physical exertion with adequate rest and recovery is of vital importance in maintaining participation and avoiding injury or illness. Now, avoiding energy deficiency means ensuring energy availability, which can be calculated as the sum of energy intake in calories minus energy expenditure through exercise in calories as a factor of fat-free mass in kilograms. Naturally, it's tricky to calculate energy availability with any accuracy outside of a lab environment, and in practice, that's one of the main reasons why it's not routinely done. Knowing that you have available energy, however, is important because it goes towards supporting basal metabolic rate and resting metabolic rate, which in adolescence can be a huge component of total daily energy expenditure. Essentially, what this means is that beyond the energy expended through exercise, a huge amount of energy is still required to ensure those extra components of total daily energy expenditure on the graph on the left are supported. And in those who are active daily, often at high intensity, sometimes more than once a day for long durations, ensuring an energy availability can be a true challenge. Through late childhood and early adolescence, energy availability has a formative role in the timing and the pattern of puberty, with consequences for adult height, muscle, bone, fat mass accrual, as well as the risk of non-communicable diseases in later life. And the quality and density of nutrition is important here, but beyond the scope of this talk today. In sport, naturally, training load around peak height velocity is paid vital importance, but pubertal development and those signs are really important to track and screen for as well. In terms of the contributing impact of resting metabolic rate in adolescence, there's a suggestion that it contributes a proportionally greater component to total daily energy expenditure. So demanding greater energy availability as a result. But research findings aren't necessarily conclusive here, and this data presented on the screen in graphs taken from a review by Cheng et al., albeit from an unspecified group in terms of activity participation through adolescence, nevertheless demonstrates that trend toward greater resting metabolic rate in puberty or in somatically developing adolescents. What is consistent is that lean muscle mass or fat-free mass and sex are both key factors in determining the energy demands at each pubertal phase. And so the energetic profile of lean muscle in the athletes that we're seeing is a really important consideration from an energy availability perspective. By way of whistle-stop reminder, the mechanism that leads to the development of the low energy availability state is driven by A, reduced fat mass, resulting in reduced circulating leptin levels, and B, reduced carbohydrate availability. These changes are detected by the hypothalamus, front and center at the top of the screen here, the thermostat of our body's physiological state, and the conductor of many downstream hormonal metabolic pathways that you can see summarized in this diagram. In reality, they're a lot more complex. The impact of downregulated hypothalamic function is the slowing down of any of these hormonal axes, including the hypothalamic pituitary gonadal axes, which might result in delayed menarche or delayed onset of periods in girls, or the cessation of periods if menarche had been established before, which will also impact somatic sexual maturation and growth and bone strength, endothelial function, and performance in both sexes. Reduced hypothalamic function will impair the secretion of growth hormone, of thyroid hormones, and even IGF-1. So impacting growth, recovery from exercise, adaptation in response to a training stimulus, all inclusive. These effects not only pose a number of short-term health problems, therefore, but they might also be associated with longer-term risks to health. And that's why this is really important to understand. Energy deficits, imbalance in, energy out, is not just about the here and now and might absolutely impact life beyond adolescent sport participation. So particularly in those who are exposed to a lot of impact-based activity, dancers, runners, etc., is this long-term risk of failure to accrue projected bone mass, and thus carry a relatively increased fracture risk throughout life because of failure to achieve your projected bone stock. Something that also isn't often discussed is the poor development of the genitourinary tract in girls in response to low exposure of circulating estrogen throughout adolescence, which might lead to later complications in gynae fertility health. In terms of bony growth before puberty, this depends in large part on growth hormone availability, but sex hormones are essential for the completion and maturation of the epiphysis and bony mineralization during puberty and adolescence. And we know that the hypothalamic pituitary gonadal axis is one of those that is extremely sensitive to low energy availability and often the first one to be disrupted alongside others. Crucially, for the adolescent, 90% of peak bone mass is accrued by the age of 18, and to a degree, it's not possible to make up for lost time here. It is possible and likely that areas of loaded bone, i.e. those that are exposed to the positive effects of impact on bone turnover, i.e. the foot, the lower leg, may be favored and protected at the expense of other areas of the skeleton during development. So we don't always actually see an abnormal DEXA result here, indicating low bone mineral density at, for example, the femoral neck, which means that these scans can be falsely reassuring, particularly in the context of bone stress injury, and remind us that measurement of bone strength goes way and beyond bone mineralization, and the response of bone to loading and the eventuality of a bone stress injury should signal to us the possibility of low energy availability. Something that's not well understood is the long-term impact of higher circulating free fatty acids and cholesterol and triglycerides in an energy deficient state, which is an established pattern that we see in adults, which carries a risk to arterial health and cardiovascular health, but it's not well studied in children. A further and important consideration is the impact of energy deficiency or mismanagement in load and energy during adolescence on long-term mental health, exclusive of contributing eating disorders at this time. Now, what we can do about it depends on what the underlying causes are, and I would suggest that these are either sport-specific or general, intrinsic within the athlete, or beyond, related to the contextual environment around them. Something that is common throughout the development of most cases that I see is insufficient knowledge, poor feasibility in terms of managing nutrition around training load, and the extrinsic pressures of the culture of the sport, and the messaging they see, what athletes might see on social media, in discussion with peers, etc. So I'm not going to go into too much detail here, but it's important to understand that underpinning most cases is simply insufficient knowledge and understanding around physiology of growth and the requirements to sometimes slow down the amount you're doing and increase the amount you're eating. So how can we recognize and protect against energy imbalances? Well, from a clinical perspective, it's really important to pick up the signs of established energy deficits. So these might present as bone stress injury, as I've mentioned before, growth delay, established low bone mineral density, recurrent illnesses, menstrual cycle dysfunction or delayed onset menarche, delayed pubertal development, eating disorders, or endothelial dysfunction, which might present as orthostatic hypotension, fainting at the severe end of the scale, abnormal bradycardia or tachycardia, or heart rate response to activity. Most cases will require a lot of input from a dietitian, and I am certainly not a nutritionist or a dietitian myself, rather I work very closely with one. And as I mentioned, education, support, but also reassurance are key in addressing and preventing energy deficits in children, but should not be reserved just for the child themselves, but for their families as well, and possibly their coaches too. This on the left-hand side of the screen is an example day of meals factored in and around training. And although food, of course, is not only fuel, when we frame timings of food in discussion with children as being fuel before training and refuel after, this can help in their understanding of the importance of how much and what they take in and around their training. And this is a good example on the right-hand side of a plate for a growing athlete. And they will need in supplementation good snacks 3 times a day with dairy, if possible, to supplement for the required energy in around training and growth as well. So always bringing it back to the fact that this is a period of growth, and absolutely it can be frustrating, and this can seem often an insurmountable ask on the behalf of the child. But if you are at a stage where you are having to address an energy deficit by reducing energy expenditure and focusing on energy intake to achieve an energy surplus, it's nice to reassure an athlete that this is only temporary, that growth will slow at some point, and a lot of people do find this difficult and challenging. And I think at this point, if an athlete is struggling, it's important that psychological support is available to them. It is sometimes at this point where we see the unveiling of mental health problems and problematic food behaviours develop or be uncovered. And so always just keep your mind open for the possibility of that at this stage. So my summary recommendations are that we aim for prevention in terms of energy deficits, and that fueling in and around growth, exercise, participation, and life that goes beyond exercise is really important. So we anticipate and we screen to our best abilities, depending on where we are located within a sporting institution. If we are unable to screen and put preventative measures in place, that we are recognizing the clinical signs of an energy deficient state early, reducing load in response and referring for medical assessment and nutritional support, plus or minus psychological support. every stage, we need to educate, support, and reassure, involving parents and coaches. And we want ultimately to be able to protect athletes to benefit from all of those great aspects of lifelong physical activity participation. Thank you.
Thank you, Dr. Amal, for an in-depth look into fueling adolescence and managing energy intake, exercise and recovery. So a few questions have come through for you. Let's start with this one, which is fascinating. Does this mean that adolescents should absolutely avoid low-carb diets? Can it contribute towards osteoporosis in the long term?
Yeah, I think it's that really interesting notion, isn't it, that a carbohydrate deficit might impact your bones, when traditionally we think about bone health around dairy intake, calcium, vitamin D, etc. And I think just what that diagram demonstrates is a carbohydrate deficit as an athlete will contribute to low energy availability because of the mechanisms I described, generally speaking. So a growing athlete will generally need much more carbohydrate than you and I tend to think. And it can be really overwhelming for them to consider even starting to eat that much. If low carbohydrate intake contributes to an energy deficit in an athlete, then absolutely that could drive that mechanism towards osteoporosis on multiple hormonal metabolic pathways. So not just the hypothalamic pituitary gonadal axis, but through the thyroid axis, through the function of the liver and the production of IGF-1, absolutely.
I guess it's also about the timing of the carbohydrate intake, isn't it, though?
Yeah.
Have you got anything to say about that?
Absolutely. And, you know, Sarah and I both work at the Royal Ballet School, Sarah at the upper school, myself at the lower school. So we are cross-site in the same institution and work with, in fact, the same dietitian. And what always surprises me is not just the requirement for carbohydrate during meal times, so as I mentioned 3 times a day, but also at snack time. And that's the fuel and refuel process throughout the day that means that carbohydrate is constantly available, which actually the pituitary really needs. So that LH pulsatility that leads to menstrual cycling and ovulation, successful ovulation, really requires carbohydrate availability every 3 hours throughout the day for that function to work.
And that's great. And it's also, I think, really fascinating when I've spoken to the nutritionists, how important it is to get the timing right around the actual exercise that they're undertaking. So, for example, there's no point in them anybody eating last thing at night before you go to sleep, because it's not so much the recovery that you need the carbohydrates, but you need the carbohydrates just around the actual time that you're exercising.
Absolutely. And that it's still important for a growing athlete to eat in the evenings. It just might be that what they need at that point is slightly more protein, dairy. But of course, it's all individualized. But yeah, I agree. I think it's often surprising to know that the timing of nutrition is important.
Absolutely. Thank you. So do you use any tools to assess your patients and dancers and other athletes that can be struggling with low energy availability?
Yeah, I mean, obviously we'll split them. So we've got screening tools, and I think screening tools are good to talk about because pretty much any clinician can use them. And they are those that pick up menstrual dysfunction, trends towards nutrition or poor nutritional habits, and also frank eating disorders or compulsive exercise behaviors. So I will use the LEAF-Q for young female athletes and the LEAM-Q, which is about gonadal function for male athletes. I might use something like the EAT26 or the DESA6 tool for eating food behaviors, and the compulsive exercise test for compulsive exercise behaviors. I might use those alongside the GAD-7 for anxiety, PHQ-9 for depression, and it just gives you an overall profile of that individual at the point that you are worried about low energy availability. In clinic, I will obviously be able to use blood tests, DEXA scans, ECGs, blood pressures, sitting, standing, to give me a bit more information.
That's fantastic. Do you find that sometimes these questionnaires are a little bit overwhelming for the athlete or dancer?
100%. And I think what's super important is that you read the patient in front of you, the athlete in front of you, and there's no point overwhelming them with information, recommendations or suggestions. And I think sometimes it takes multiple conversations before we can garner all of this information. And it might be that, for example, you as the first port of call clinician may not choose to undertake those assessments, and it might make more sense for the questionnaires to be undertaken by a specialist, at which point hopefully the athlete is prepared.
And one last thing, we've just got seconds left, but I want to leave with this key point, and I'm sure you'll be able to answer it brilliantly. Are periods important? Do they really matter?
Oh, Sarah, periods are so important. When you start your period is important. So the age at menarche is absolutely key, particularly for bone health, future bone health. The regularity of menstrual cycles, it's an outward barometer of your internal physiological health and well-being. Encourage all of your young female athletes to track their periods, not just adolescents and beyond. Picking up subtle signs of changes in menstrual health, super important. The loss of a period is a significant medical sign, and I think at that point you really need to be referring for further investigations. That might be low energy availability related, or it might represent a gynecological or even pituitary condition. So it needs to be acted upon quickly.
That's fantastic. Thank you, Amal. Yeah, so Amal and I both see a lot of this in our clinical practice, and it's wonderful to work together. Thanks very much.
Hi.
So our next speaker is Professor James Hull, who is a consultant respiratory physician at ISEH, and he's giving a short presentation on another favourite topic of mine, breathing concerns in adolescents. He holds a PhD in lung and exercise physiology. With 12 years plus experience working for the NHS and top UK sports teams, he's now the international voice in how to breathe to achieve. So over to you.
So it's a pleasure to join you this evening on what is a fantastic programme looking at all aspects of sports medicine and adolescence. And my challenge is to talk about breathing problems, breathing issues in adolescence. Thank you very much for the introduction. And just as means of a further background, I work as a respiratory physician at the Royal Brompton Hospital, but I'm very interested in sports respiratory related issues and lead the service at the ISEH, but also have an interest in helping Team GB by the English Institute of Sport. I should also add that I've been involved with some task force or guideline documents over the past 12 months for the International Olympic Committee and the British Thoracic Society, and I'll touch on some of those later on, but they're useful sources of information if you want to read about any kind of issue relating to respiratory problems in athletic individuals. I think I should also say that as an adolescent myself, I was a rower and a cyclist, and I was pretty useless in the sporting arena. And actually at the time, I blame that on my breathing, which probably sets the scene for what I'm going to talk about today. I'm going to take the slightly unusual step of giving you the take-home messages at the very start of the talk. And I want to give you 3 very simple take-home messages, and then you can go off and check your emails or do other things while you're listening to this. But at least you've got the important messages. And the first take-home message is to get the diagnosis right when you're seeing an adolescent with breathing issues. It sets the scene for everything else that we do, and it's vitally important, as I'll share with you, that the diagnosis is absolutely right and made with robust investigation findings. The second thing is get the diagnosis right because you need to get the treatment right. And as you'll see again, if we don't understand the problem and the issue that's causing the breathing issue in an adolescent, then we're going to use the wrong treatment. And the third thing, as you might have guessed already, is to get the diagnosis right, because then you avoid giving inappropriate treatments. And whilst many people think respiratory type treatments are pretty benign and things like the blue inhaler are not necessarily going to cause major side effects, they certainly do, and they cause a number of issues which we would wish to avoid unless they're absolutely necessary. So let me introduce you to a young adolescent athlete who's referred with breathing issues and wheezing sounds. I'm going to play a video that she recorded, or a family recorded, as she was running in at the end of an exercise session. And of course, when she presents to a clinician, she reports wheeze, breathlessness, an uncomfortable sensation, as you could see. And she's not alone. So if we look at a questionnaire survey asking athletic individuals, when you exercise, do you struggle with respiratory symptoms such as breathlessness, chest tightness, or wheeze? we find these are incredibly prevalent issues. Maybe up to half of people within the prior 12 months had reported a problem with their breathing, and you can see the very high prevalence reports of wheeze and cough in the context of exercise. Another way of looking at this is to say, let's ask doctors, for instance, how often they see athletic type individuals who are seeking consultation with respect to respiratory problems in the context of sport. And we did exactly that in a paper we published in 2009. And again, remarkably high number of individuals presenting, reporting problems with that. You can see that, for the general practitioners who were surveyed in this questionnaire, that they were seeing these sorts of cases perhaps at a frequency of once a month. And so not an infrequent issue to be able to tackle, deal with, and actually help people with an important and prevalent issue. And what happens when people, clinicians see individuals with this type of problem, the wheezy athletic individual? And so in the survey I just showed you some data on in terms of the epidemiology and the presentation patterns, we asked doctors, what do they actually do when they see that type of presentation? Someone presenting who says they're wheezy and breathless during sport. And the majority of doctors go on to perform some form of investigation, but about 1 in 4 initiate treatment based on that type of presentation. When investigation is undertaken, it's usually investigation with measures such as peak flow, but sometimes with spirometry when it's available. And if treatment is initiated from the initial assessment, it's usually with the short-acting beta-2 agonist or the blue inhaler salbutamol. And so the point I want to emphasize from this study, which I know may have changed because it's slightly outdated now, is that really everything is focused on asthma investigations, asthma type treatments. And I'm going to challenge that notion today by sharing with you a number of slides within this presentation that show that there are other causes of breathing difficulties, and getting the diagnosis right is so crucial to help get the treatment right. So it isn't perhaps unsurprising that people focus on asthma in the context of sport. There's an awful lot in the media, in publications, in social media, and in the press to suggest that actually asthma is incredibly common in athletic individuals. And of course, there's a background and well understood high prevalence of this condition. And so it's logical to think that anyone who presents with wheeze and breathlessness in exercise must have a diagnosis of asthma. We've spent time, certainly within the last year, looking at the prevalence of asthma across sporting groups and individuals. And you can see that, yes, it's quite right that it's a high prevalence in sporting contexts, particularly in those who perform endurance-based sport or winter or aqua-based sports, where as many as 1 in 4, or maybe in some series, 1 in 3 individuals might actually have objectively confirmed evidence of asthma. So a really important differential diagnosis to consider, but not the only thing to consider. And so at the ISEH, we run a dedicated sports respiratory clinic that we've been running for a number of years now. And if I break down the type of cases which get referred, perhaps unsurprisingly, the most common type of clinical scenario C is an asthma-related issue, a wheeze or breathless individual, perhaps with coughing also. And of course, we see individuals with recurrent infections or unexplained underperformance or chest pain issues. So a few years ago, we started to think about what are the different causes of breathlessness and wheeze in athletic individuals. And we undertook this study that was done in Leeds and with colleagues, particularly Oliver Price, who works with me as a colleague up in Leeds. And essentially what we did was we decided that we'd think about what causes breathlessness and wheeze in individuals who are running and pushing themselves really quite hard. And we used as an exemplar of that the park run, where people are trying to get the best time possible over a 5K run. I'm sure many of you partake in the park run every Saturday morning. And at the end of the race, or the timed run, when you're running into the funnel at the end, people are pushing themselves pretty hard. And we decided that actually it might be a good time to see what is happening to breathing and breathing sounds when people are running into that final funnel. And so we recorded the breathing sounds in individuals undertaking the park run. And what became apparent was that actually there are a number of people, as many as 1 in 10, who were struggling with symptoms of breathing difficulty, but also had an audible sign of some breathing dysfunction when they were running at the end of the park run. And you might say, well, that's maybe to be expected because a number of them will have asthma. But what we actually found was when we analyzed the audio sounds, that actually a higher proportion of individuals were running in with a wheeze on inspiration or inspiratory stridor, and that really dwarfed those who were running in with an audible expiratory wheeze. And so when we think about the nature of what's happening when people are getting breathless and when they're exerting themselves, actually, there are all sorts of places in which wheeze may be generated within the respiratory tree. And so that led me to work very hard over the last few years on trying to understand the different conditions that can cause breathing issues, and then to articulate that for a clinical statement with the British Thoracic Society in order to help people unpick this problem and get individuals with breathing problems through the best types of tests and to the most effective way to get them the right diagnosis. And this resource is free at the BTS website, although it's vitally important you don't look up the wrong type of BTS, because the British Thoracic Society is always vying for attention from a K-pop band called BTS. Within that document, we outline how you should approach the assessment of the breathless, wheezy athlete. And of course, it's important in the clinical context that you go through and identify important red flags, such as the presence of coughing up blood or pleuritic chest pain. You can see these red flag conditions on the left-hand side of the screen. But the point we really emphasize is that for most individuals, particularly adolescents with exertional breathing problems, it comes down to 3 diagnoses. The diagnosis of asthma, which I've already highlighted, a condition called exercise-induced laryngeal obstruction, or EILO, which I will share with you some data on in a second, and this final differential of BPD, or a breathing pattern disorder. Now, for many, many years, people have known that not all wheeze is asthma, and of course, any turbulence within the airway can give rise to wheezing type sounds, particularly if you're pushing a lot of air over those areas of the airway. And if I could ask you to take nothing else away from this talk other than this particularly important message. If your athlete reports that they can hear a loud wheeze and that others, including their coaches or the other competitors around them, can also hear that wheeze, I would suggest to you that you think strongly about whether that wheeze actually might be coming from a higher part of the airway rather than the airways that narrow in the context of exercise-induced asthma, and particularly to focus on whether the larynx may be closing in a condition called exercise-induced laryngeal obstruction. And the 3 conditions I mentioned in those key differential diagnoses have different characteristics in the context of exertional breathlessness. So if we just take these in order and consider ILO, the condition where the larynx closes up, it tends to cause breathing issues and wheeze that occur very closely aligned with peak exercise intensity, and then rapidly abates on exercise cessation. Whereas exercise-induced asthma, or EIB, tends to be a phenomenon which occurs when people stop exercising and then slowly recovers over about 30 minutes. And this third entity of a BPD, or breathing pattern disorder, is very erratic with symptoms which can be present even just climbing flights of stairs. With ILO, of course, the obstruction is occurring in the extrathoracic airway, and so people report an inspiratory wheeze, a very loud wheeze, as I showed you on the previous slide, and some tightness in the throat, very much like the video that I first started this talk with. Whereas EIB, the wheeze is very much more of a shallow sound, and it occurs on expiration. Now, you would think, having understood some of the different characteristics and the nature of these sounds, it'd be very easy to unpick these issues from just listening to a history and the clinical story. But a number of studies have shown that actually it's incredibly difficult to try and discern these features. Here's a very famous study from almost over 20 years ago now, which showed in winter sports athletes, if you ask them about coughing, wheezing, tightness of the chest, and then you put them through decent objective tests for asthma, you might as well toss a coin in the air in order to determine whether they have exercise-induced asthma or they don't. And that, of course, probably is because of this differential and the diagnoses that I've mentioned already, which act to mimic exercise-induced asthma. And so it's vitally important that when you assess an athletic individual, you don't rely necessarily on the history or the findings on an examination, which don't really take you very further forward, and you obtain some form of objective assessment. And by objective assessment, the type of tests that we do at the ISEH include tests that look very high quality tests that look at lung function with a test called spirometry, but also tests which challenge the airways by getting athletes to breathe in and out a very dry, cold air, and then to look at the lung function before and afterwards to really objectively confirm a diagnosis of exercise-induced asthma. The big differential is this condition, ILO, or exercise-induced laryngeal obstruction. Here you see some laryngoscopic videos to the back of the throat, and you can see the vocal cords nicely patent on the right-hand image, but on the left-hand side, you see the curling over of the structures above the larynx, causing an obstruction in the classical form of ILO, which was present in the video of the girl that I showed you at the very start of this talk. And of course, not all wheeze is asthma, but wheeze in this case is arising from closure of the larynx. This is a condition which is classically diagnosed by putting a little camera in and then getting someone to exercise to the point in which they bring on their symptoms. But as I'll show you on the next few slides, can be diagnosed in far more simple ways, or at least can be progressed as a potential diagnosis in far more simple ways. But in an adolescent population, this is a really important differential diagnosis, and in Scandinavian series may be present in as many as 5% of the population, adolescent population. So it's vitally important that it's not overlooked as an important cause of wheeze and breathlessness in adolescent athletes. Now, I mentioned a simple way to try and discern or think about this in your own clinical practice. Not everyone has cameras that they can put down the back of the throat and exercise people. One way that I recommend to people is to try asking an athlete to take a selfie type video. Importantly, of course, that they're exercising at the time they take the selfie video recording, but then they can present that to you to show the nature of their symptoms, their wheeze and their breathlessness, and you can pick apart whether there's a presence of the inspiratory wheeze and stridor that's classical of exercise-induced laryngeal obstruction, or the expiratory and much quieter wheeze that's present in exercise-induced bronchoconstriction or asthma. Why are we doing all this? Well, the reason we're doing all this is because we can then target the right treatment. If we have a confirmed diagnosis of exercise-induced asthma, then of course we can use the best type of asthma treatments to make sure that is treated properly. But if we detect breathing pattern disorders or exercise-induced laryngeal obstruction, then we can get young adolescent athletes to see our fantastic respiratory physiotherapist team at the ISEH, and particularly Julie Moore, who can help with breathing exercises, which make a huge impact on controlling these symptoms, and of course allow us to not to use the correct treatments and avoid giving unnecessary asthma treatments. So I'm going to finish there with a very brief overview of some of the key issues that I think are important. And if I could give you the 3 take-home messages again, it's vitally important that we get the diagnosis right. And if you take nothing else away, then I hope you can take away that we must remember in adolescent athletes the differential diagnosis of exercise-induced laryngeal obstruction, which is a common cause of breathing problems. If you get the diagnosis right, then you can often direct people to the best treatments, such as breathing respiratory physiotherapy to help with the difficulties. And of course, you can remove inappropriate treatments and unnecessary escalations, for instance, in asthma treatment, which are associated with their own set of toxicity. I'm going to thank you there. These are my contact details. I've flagged up the British Thoracic Society statement, which is free to access on the British Thoracic Society guideline. And please feel free to drop me a line via any of these contacts if you have any questions. Thank you very much.
Dr. James Howell, thank you very much. A great resource for all things breathing related in sport and to understand how to get the diagnosis right in breathlessness. So breathing discomfort on exertion is something that I see very, very commonly within track and field athletes as well as in darts medicine. Thank you so much for challenging the notions that asthma is the only diagnosis here. So a few questions have come in for you. So how can breathing tests be used as a measure of recovery?
Wow, I mean, generally speaking, we haven't used them in that context, or there isn't much in the way of published literature to suggest that. But certainly, I mean, for instance, if you look at people recovering from a pneumonia or from a flare of asthma or airways disease, then of course you'll want to see that the lung function breathing tests are returning back up to normal or baseline values to help guide you in that respect. There's some emerging data as well, which I think is of interest in the way that we look at the way breathing changes in and around the context of vigorous exercise, particularly the frequency of breathing, that I think we'll see more emerging. So people look at things like heart rate and heart rate variability, but I think over the next few years, we're going to see more data measuring breathing variability as a mark of recovery, especially from viral infections.
And how can we rehab inspiratory and or expiratory stridor on exertion. Is there any way to actually rehabilitate this?
So if you're asking about exercise-induced laryngeal obstruction, which causes inspiratory impairment, yeah, I mean, therapy-based intervention is the frontline gold standard go-to treatment, and it really takes dedicated respiratory physiotherapists or the expertise of that group of practitioners to work on trying to modulate the way air enters the back of the larynx and enters the lung. So most people in this field now think that the reason that develops is because as you've got a maturing larynx when you're an adolescent, and then you start to drive huge amounts of air over the back of the larynx, as the air has to sort of traverse the narrowing of the larynx and decelerate, it causes a pressure drop which pulls the structures in. So the therapy and rehab is based on trying to modulate the way air goes in through the larynx and through that right angle bend. And if you can modulate that slightly, you can reduce the pressure drops and then keep the larynx open and allow athletic individuals to continue to exercise without that impediment.
Fantastic. And in terms of talking about as adolescents in particular, are there any typical teenage stresses in life where, such as anxiety, where this may interrelate with breathing issues for this particular group?
Yeah, and so, well, one thing I'm always keen to stress is that just because someone has noticed a problem with their breathing, or they feel that they're sort of hyperventilating or taking too much air in, there's a sort of instant assumption that it must be something psychological, there must be an anxiety underneath it. And then often, we find there isn't. There is some other pathological or other process, a bit like laryngeal obstruction. Having said all that, we know that when we look at the wiring diagram of how breathing is intrinsically controlled, it is very closely aligned with the stress and strain centers within the brain. And so if you look, for instance, with functional MRI scans in people who become breathless, the sorts of centers which glow up in states of anxiety or high levels of stress appear to glow when people get dyspneic. And so it's probably that there is overlaps from an evolutionary perspective in terms of the way breathing and heightened breathing responses were needed to sort of take us away from fight or flight situations. And so, I'm always keen not to assume that breathing issues have an underlying anxiety or psychological issue, but it's remiss not to think about that or how those things can interplay and have that sort of conversation so people understand that if you are stressed or you are under a lot of pressure and your breathing system is slightly vulnerable or dysfunctional, that whole process will just get more amplified unless you focus on trying to help people understand the interplay.
So do you work quite closely with psychologists, counsellors, and so on, other multidisciplinary team members to help with your management of these breathing issues?
Well, I work incredibly closely with the respiratory physiotherapy community and also speech and language therapy community. And I think it's fair to say that, a huge part of their training and their expertise is psychologically leaning. And so, yes, we do use psychologists and that group of therapists in specific circumstances. By and large, I find that the therapists that I work with, physiotherapy particularly, are very well versed in trying to untangle and help adolescents with these sorts of issues. And so, generally speaking, we start with that sort of approach, and then if dedicated psychology input is needed, then of course, yes.
Yeah, fantastic. What is the impact of inhaled corticosteroids on growth and development in adolescents and young people?
Yeah, it's a question I get asked a lot, and of course there is concern, rightly, from parents, particularly about if they see their child or adolescent on an inhaled steroid, as to whether this might have an impairment in them reaching their sort of peak bone density and their velocity. We heard from Amal's talk previously. What I would say is two things really. One is, of course, we want to use steroids in the right way, in the right situation, and so it's important that the diagnosis is correct, and that if there is evidence of an inflammatory signal in good objective tests, that yes, we may have to use inhaled steroid, but we should use them at the lowest possible dose to control the symptoms. And generally speaking, if you can get down to a low dose and you're not giving people excessive amounts of steroid, data supporting a longer term impact on bone maturation in adolescents at least is relatively sparse. And so using the lowest dose at the right time in the right situation and when it really is needed is the key priority here. And of course, the other thing to say is if you inadequately treat an inflammatory condition, then that can lead to flare-ups that require oral steroids, which of course comes at a far greater cost to the bones and to skeletal maturation.
Yes, of course. Thank you very much. That's very helpful and very insightful. So we'll move over now to Dr. Noel Pollock, who is a consultant in sport and exercise medicine at the ISEH, Chiswick and Chelsea. And he's giving us a short presentation on common lower limb problems in adolescents, a subject in which he is greatly versed. He has published widely cited work on muscle injury classification and rehabilitation, as well as other aspects of sport medicine and elite athlete health management. And he's highly regarded by his peers. He has 15 years prior experience as the team doctor for British Athletics. Over to you, Noel.
Thank you, and it's a pleasure to talk to you this evening on adolescent lower limb injuries. I'm a consultant in sport and exercise medicine at ISEH and Chiswick Medical Centre. Previously team doctor for British track and field, which is the reason for the plethora of track and field images throughout the presentation. So to start and to place the presentation in context, there's a broader context here of the importance of increasing physical activity in adolescents and keeping adolescents in sport and exercise and keeping them active as a social and public health priority. And obviously, good injury management is an important component of that. That said, in our clinics, we usually see these type of young adolescent athletes who are very engaged in their sports and usually competitive sports, and are balancing that with all of the other life changes, social changes, and academic pressures that go on in adolescence. Just a word on parents who are often incredibly engaged in their child's sporting endeavours. They're obviously a hugely important part of the consultation and the assessment, both in terms of understanding their role and educating them in the nature of the injury. And it'll be important to be well informed so that they can have good discussions about decision making on sport and exercise, about load management, about coaching and other influencers on their child's sport. But it's of course always important for us to be mindful of and have at our centre the adolescents and the patient's wishes and concerns. Be cognizant that there may be hidden information, and parents may not always have their child's health as the priority. They can be very engaged in competitive success, and it's important that we, as their doctors and clinicians, retain a focus on the health and well-being of the adolescent. If there are any concerns about this, I think really important, at very least, to share the case with a colleague to discuss through your thoughts. And then just before moving into individual injuries, I'd like to talk more generally about growth and maturation and risk in adolescent athletes. Obviously important to consider both chronological age as well as biological and skeletal maturity. Female growth accelerates from age 9 to 10, has peak height velocity around the age of 12. Whereas in males, it's slightly later. But it's important to recognise this individual, and if this follows a normal distribution, a third of adolescents will be outside these normal growth acceleration windows. And so it's important to consider the individual in front of you and where they are in their development. Recommend this excellent paper on maturity associated considerations on training load and injury risk mainly coming at it from a soccer academy perspective, but some really interesting discussion in here on concepts of adolescent awkwardness around peak height velocity with accelerating limb growth, whereas coordination and soft tissue and muscular control may take some time to catch up, and the associated injury risk with that, and the consequences that might have for decision making on types of exercise or drills or sport patients should do around the time of their peak height velocity. An awareness of the differences in adolescent bone is obviously important. Injuries to the physis carry with them important potential complications, and I will talk more shortly about the secondary ossification at the apophysis, where the tendon attaches, and this can be a vulnerable site for injury. Classically, our risk management in adolescent athletes often focuses on load and overall load, particularly around times of accelerated growth. But I think it is important that we consider other risk factors. One such risk factor may be technical development, and these two athletes who perhaps both present with Sever's calcaneal apophysitis, if we don't recognize that this athlete in the White Sox is landing with a 4-foot landing on every run and on every stride, that's potentially something that we miss in correcting or addressing or considering in the management. Often this may be something that's neglected in coaching, and I think it's important that we can pick up some of the technical factors that might be involved in injury presentation. Also in considering not just overload, also important to think about strength training in adolescents. There's often some concern about introduction of strength training, but there are some really good position statements from American College of Sports Medicine being one, and the Faculty of Sport and Exercise Medicine in the UK, demonstrating that there is substantial evidence on both performance and health benefits of regular resistance training in adolescents. And this is reflected in the more research that's also coming across the lifespan, and the importance of strength training and resistance training. So this, I think, is also something important to think about and consider applying with our younger patients. And just finally, a recognition on excellent resource that's available on the FIFA 11+ Kids Injury Prevention Programme, demonstrating a reduction in injury rates. And this is something really useful that can be incorporated into warm-ups or an isolated exercise session or rehabilitation session for development of muscular strength and neuromuscular coordination in children. So perhaps in prevention, whereas traditionally we may think about overload and concerns about early specialization and reduce activity and encourage rest, perhaps we can consider a more empowering approach that encourages the development of technical skills as well as tactical development in the sport, that encourages the development of good strength characteristics and competencies, and also use potential injury presentation to discuss generally about good recovery practices that will support development. Second part of the talk, I'd like to talk about a couple of common presentations in the adolescents. And firstly, apophyseal injuries and apophysitis. So traction apophysitis is a traction injury to the bony attachment of tendons in adolescents. Eponymous Osgood-Schlatters and Sinding-Larsen Johansson syndromes around the knee, Sever's apophysitis in the heel, and Rec-Fem apophysitis at the Rec-Fem origin, being common presentations. These often present with a gradual onset of symptoms, and patients initially continue to play. They present with focal tenderness, pain on stretch, and resisted contraction of the affected muscle, and a bony prominence and local inflammation is often present. Ultrasound scan is usually sufficient in clinic to diagnose these, but do consider MRI or X-ray if there are some unusual characteristics in the history or some red flags. In managing apophysitis, education and discussion and explanation is really the most important element of management. Linking load and adaptation and recovery, and having a really good discussion about those different elements of sport and adaptation to sport, important both in this injury management, but also those general principles are really important just generally in sport, and important education for the young athlete. We may want to modify some of the higher risk loads, such as overall volume or volume of jumping or long kicks or powerful shots. We may want the patient to go through all of the sports that they do and prioritize the sports that they really want to focus on. And it's also an opportunity to work on other aspects of athletic development, including strength, as well as neuromuscular coordination or technical developments in their sport that we've already spoken about. Symptom management is the second management consideration. Heat ray is really useful for calcaneal apophysitis presentations, along with review of footwear. I do think topical or oral anti-inflammatories can have a short-term role, as can shockwave therapy, particularly in apophysitis around the knee. My personal preference is not to stretch. I think stretching connective tissue is likely to put increased strain around the tendon attachments, and I don't recommend stretching in the management of apophysitis. And similarly, we usually prefer heat as part of a general recovery strategy rather than lots of icing, but short-term icing can be useful, I'm sure, after the sport. Also important to consider apophyseal fractures, which can usually present with more acute incident in either kicking or on sprinting, and this may occur in the background of apophysitis. MRI is usually an investigation of choice here. Management is usually non-surgical, but you can consider surgical reviews if there's excessive displacement. These recovery and these follow a bony type timescale, initial period of non-weight bearing before progressive rehabilitation that moves through the standard phases of rehabilitation and rehabilitation loading principles. Also should be aware of some of the potential long-term complications, such as exostosis that we see here, or increased risk of FAI presentations. And then secondly, to consider bone stress injuries. So bone stress injuries from the bone remodeling is not sufficient to deal with the strain and the load that's placed on it, and it can progress through stress reaction and stress fracture. Risk factor assessment is incredibly important in the history, and these are some of the factors that should be considered within the history. A review of the load, consideration of biomechanical factors and muscle weakness, some of the underlying bone health issues, and particularly a discussion around menstrual function is important in considering these injuries and in the injury management. These are some of the high-risk stress fracture sites. Of course, it's important to diagnose any bone stress injury accurately. It's important to diagnose these early. A huge difference in return to play times if we pick them up at the stress reaction stage and introduce appropriate management. We can get people back to sport usually in about half the time, as opposed to the high-grade stress reactions or stress fractures, and avoid the sequelae of potential sequelae of stress fractures, particularly some of those high-risk stress fractures. MRI is important for diagnosis and grading of stress reactions on their potential progression through to stress fracture. MRI vibe sequences provide useful information, particularly around bars, stress fractures in the back. And usually DEXA scan and blood testing completes the investigative workup. Correcting those risk factors that I mentioned, as well as putting in place a structured and creative rehabilitation that has adequate stimulus for bone healing and can be carried through into that athlete's normal training is usually important during the rehabilitation of bone stress injuries. And then finally, a word on growing pains, which isn't a useful diagnostic term, but it is important to note that you can have transient biomechanical overload and related pain associated with that at times of growth. But if you do consider this as a presentation, do have in mind the timescales, short timescales that you would expect it to recover over, and be mindful of some of the potential more significant diagnosis and pathology that might be present. And then finally, just to mention three more significant injuries that are really important not to miss. And if any of these red flags are present in your history, you should consider a more significant and serious pathology. It's important that every adolescent presentation, or indeed every presentation to MSK clinics, that we spend at least a little bit of time considering whether the presentation in front of you could be something more serious. I'd like to comment on presentation of the hip with slipped upper femoral epiphysis, shown classically on this X-ray here, but early MRI scan may be more subtle. These patients will present with a hip pattern, particularly internal rotation being aggravating. Now, obesity is and males are more commonly represented in this presentation, and this is sort of a classic presentation. But if 50% of cases are obese, that means that half your patients presenting with SUVI will not be. So do have it in mind, particularly with a limping child who presents with hip signs, and arrange appropriate investigations, and the management is surgical. Tumors are important masqueraders of soft tissue presentations or sports injury presentations. These are some of the common ones, but if any of the red flags are present, do arrange appropriate investigation and referral for these. And finally, in the multi-joint presentations, usually do consider juvenile idiopathic arthritis, particularly for knee effusion, for example, that has an atraumatic cause. There are a number of different types of this condition that may have symptoms around the enthesis or systemic symptoms. And investigations are bloods, imaging, and rheumatological involvement. That concludes my talk on adolescent lower limb injuries. I hope you find it of interest and of use in your clinical practice. Thank you very much.
Thank you, Dr. Noel, for a succinct overview of lower limb injuries in adolescents. Very insightful points that you've made there. But a few questions have still come through for you. So how might you modify training around peak height velocity?
Yeah, thanks, Sarah. So there is a potential increased risk of injury around peak height velocity, and the alteration of training through the different phases of growth. There's lots of discussion on this and no clear evidence. There are some proponents of ideal windows of opportunity for enhanced training, but that hasn't been consistently shown in the literature. What I think we do know, I think we can apply, is that this concept of increased adolescent awkwardness or reductions in neuromuscular coordination around peak height velocity. Applying that to training programs, you may reduce heavy decelerations or change of direction work around that time, and concentrate more on skill acquisition and technical development. So that they may be some of the adaptations that you would put in place around peak height velocity time. But much more work needed on that.
So it's inconclusive at present. So another question, does the reduced motor control in growth increase ligament injuries due to poor biomechanics?
Yeah, so this is a similar question, and again, it's piecing together bits of evidence to inform our practice about what's best for the patient. So yes, there are periods of reduced motor control around accelerated growth. We know that injury prevention programs that have a neuromuscular component or a coordination and skill acquisition component to that are useful in injury prevention, and therefore applying those principles to include them within rehabilitation and to improve the neuromuscular coordination around times of accelerated growth should be important. But of course, there are some children and adolescents who have got very good skill acquisition and very good neuromuscular coordination, and therefore we do not need to necessarily be so protective or necessarily have such a component of that within the rehabilitation programs. But certainly, I think it's a quality that we should assess in clinic and on the field, and apply appropriate rehabilitation to if we detect it.
I think this is what we were saying before when we were talking about how there's such a variety of individuals within this cohort of adolescents, and they range from 13 up to 19, and just sort of looking at trying to get strategies of management across such a wide age range is obviously very difficult, and you have to tailor all of that, don't you?
Yeah, very, very much so, both from a physiological and biological, but also psychological and the way they interact with their coaches and their healthcare professionals and their parents and all of these people, all very individual, and being able to be adaptive in your approach to that, I think, is one of the challenges working with adolescent athletes.
You mentioned magnesium in passing for recovery. Are these topical sprays? How do they work?
Yeah, what a good question, and a pickup of one word on a slide. Well done. Yes, so magnesium is something we're very interested in British athletics. Magnesium is an important mineral for athletic performance. It has multi-system effects on strength, on neuromuscular function, and we did some blood work assessing magnesium status in athletes, and for a number of reasons there are athletes are more vulnerable to magnesium deficiencies, and we did find that over an 8-year period, athletes that had lower magnesium were at greater risk of, or there was association with increase in both muscle injury and tendon injury. So I think it is something that's worth consideration in a comprehensive management of an athlete or a patient. And for recovery for that reason, it can be absorbed orally, but can also be absorbed in the skin through the skin. So Epsom salt baths, magnesium salt baths would be something that I would suggest is useful for recovery, both from a heat within the bath and potentially magnesium absorption through the skin.
And would you be saying that magnesium is more important than other elements such as copper, zinc, for recovery and musculoskeletal health?
No, I don't. I wouldn't say that. I don't, although I haven't researched that or looked at that. But
I think some people
one
out there
step at
might
a
be
time.
thinking, yeah, and some people out there might be thinking, well, why magnesium?
Yes.
Why copper? Why any of it? You know, why not all the other elements in the periodic table?
Yeah, well, when I get to researching those, and if we get any any evidence for those, we'll add them to the list. I think there is lots of there could be rationale for lots of treatment approaches, and this is always about sort of looking at what evidence there is. Does it have rationale behind it, and if there's a compelling rationale, as there is with magnesium, given its role in multi-systems and in pain. So it does have a role in a pain receptor called the NMDA receptor, which magnesium is involved in that receptor. So there are some reasons why magnesium might be important or more important, and then you start looking at some associations with injury and deficiencies in athletes. Then it becomes an interesting story with a little bit of evidence and a fairly easy thing to correct. And it's nice to have a warm bath for recovery as well. So if you can add some magnesium in there, then go for it. But it was a small part of
a tiny snippet of a bigger talk. Yeah, absolutely. Yeah. And thank you very much, Dr. Noel Pollock, for presenting on common lower limb problems in adolescents. Thank you. So we're now moving on to Dr. Richard Sylvester, who is a consultant neurologist at ISEH. He's presenting on managing return to activities after concussion injury in adolescents. And he holds a PhD in cognitive science, cognitive neuroscience from UCL, and runs a general neurology practice, seeing wide-ranging neurological disabilities, as well as a dedicated clinic for neuro rehab after traumatic brain injuries. So over to you, Richard.
So, hi, I'm Richard Sylvester. I'm a consultant neurologist based at the Institute of Sport, Exercise and Health. And I'm a specialist in traumatic brain injury, and I run the complex concussion clinic and also the brain health clinic for retired contact athletes with cognitive concerns. So today I'm going to talk about concussion management in adolescents, and in particular, looking at returning to normal activities following concussion. So what are the issues around concussion? Firstly, there's the issues on the field, and a lot of emphasis is based on management of the acute injury. Here's a football match, not adolescents, FA Cup, and there's a head injury with tonic posturing. And this is a guy from a lower league club that I saw a couple of years ago, and it was a pretty nasty injury. He was out for a few months with symptoms, and eventually when he recovered and I was asked to see whether he was okay to return to play, he came with a physio, and during the course of the conversation, the physio asked me, it was really interesting. He was knocked out. He was doing this tonic posturing, which is a classic feature of a brain injury. And, he was tended to, taken to A&E emergency ambulance. And when he got to A&E, they put a neck collar on him, and the physio couldn't understand why. That was a little bit worrying that the management of his head injury on the pitch didn't include immobilization of his cervical spine. So there's still things to get right in the management of acute injury. But really the key with head injuries is avoiding exacerbating an injury. So these are very rare cases, but there's a condition called second impact syndrome, which has been described mainly in younger people and adolescents, where a second impact following a first causes catastrophic outcome, usually death. It's not really clear whether the first impact is actually a more severe brain injury than is realized, or whether it's an actual syndrome. Unfortunately, it's extremely rare. But I think the key is that when someone has a significant head injury, you have to assume it's pretty bad, and they have to be removed from play to avoid any exacerbation and managed appropriately. Next thing is that when someone suffered a concussion, their risk of further injury, not just head injury or concussion, but musculoskeletal injury, is significantly raised for 6 months. This is data from adult rugby players, but there's similar data in footballers, both in male and female, in hockey players, and in adolescents in a number of sports. And essentially, this is just shows that the cumulative survival, which is time to next injury, is significantly reduced in people with concussion, which is the bottom line, compared to other forms of injury. And that's really interesting to me. To me, that suggests that either there's something not quite right with the brain still, even when people are fully recovered after a concussion, or the rehabilitation that currently is offered is not particularly effective. So what about issues off the field? Well, most of my clinic is based on persistent symptoms, and there's been many things in the press about established international rugby players mainly, but other sports people having to retire because of persistent symptoms. And this is the previous captain of Saracens, who I saw, who had to retire because of ongoing problems following concussions. Then there's concerns about long-term effects, which I'm not really going to go into today very much. This has led to calls for action. So children are being left exposed to serious and catastrophic risk of injury, and they should not be, according to people. And there have been calls that children should be completely shielded from contact sport. And this has undoubtedly led to reduced participation. So on the left here, we have a device that is available in the States, an American football helmet with a impact sensor in it that links to parents' mobile phones, so that when their kid has a significant impact, they can rapidly call the coach to make sure they're off the pitch. And it's not a long step to realize that rates of participation in contact sports such as American football have been drastically reduced in school and college level in the States. And, you know, while for some people that may be a good thing, we know that activity, team sports, including contact sports, has incredibly good health benefits. And we want to avoid the situation down the bottom where other activities lead to less tangible health benefits. So what's the scale of the problem? Well, there's quite a lot of data, and it depends what sport you play and at what level. So you can see that horse racing, the concussion rate per 1,000 player hours is very high. Boxing, quite high. Rugby, quite high. And youth rugby seems to be quite a lot lower, but probably underdiagnosed. I would ignore the soccer and NFL data there for various reasons I'm not going to go into. And this just is a graph showing the rate of concussion diagnosis in the English Rugby Premiership over the years. And you can see that in 2012-13 season, there was a huge increase the next season, actually, in the diagnosed concussions, which has increased. Now, if we looked at more data, has plateaued. And this wasn't because the way rugby was played changed. This was because in 2013-14 season, the head injury assessment protocol was introduced. So diagnoses of concussion that were being missed were suddenly made, making it look like there was a huge increase. And this would be the case in football, and I'm sure it would be the case in lower levels of rugby as well. So what is concussion? Well, it's actually not a very easy question. And to me, concussion is a brain injury. But the trouble is we can't really definitively show brain injury in most people that have suffered a concussion. So we're left with a syndrome, and it's a collection of symptoms and signs, such as headache, dizziness, visual disturbance. There's balance impairment, often behavioral change, cognitive impairment, drowsiness, and disturbance of sleep-wake cycle. This is from the World Cup final 8 years ago now. It's a German player who you can see up here was out cold within 20 minutes, carried on playing. The story is that at halftime he went up to the referee and said, "What game is this?" which everyone was a bit worried about. So he was removed from play at that stage. He'd managed to play about 35 minutes pretty poorly without anyone noticing there was anything wrong. And he was suffering from post-traumatic amnesia, had no memory of any of this. So what's going on in the brain during concussion? Well, this complex slide essentially just shows that there's an electrobiochemical cascade triggered by trauma, which has a number of downstream effects. This is an axon here. This is tau protein, which is the scaffolding of the axon. And axonal damage causes disruption of the tau cytoskeleton and release into the surrounding brain parenchyma. And that's toxic. And we think that tau deposition is probably the substrate for neurodegeneration, which is not the subject of the talk today. So what's the current management of concussion? Well, it's the 4 R's: recognize, remove, rest, and return to play. There's problems with all of these. So recognition and remove in principle sounds very simple, but the diagnosis can be very difficult. So most people don't lose consciousness. Most people don't have tonic posturing or severe ataxia. So observable signs are often absent, or they can be missed. And there's lots of data showing that video replays in the professional game pick up observable signs of brain injury that are often missed to the naked eye. There can be delayed onset of symptoms, and there's a real problem with a lack of objective markers. So the concussion recognition tool, or SCAT test, has been developed to try and help with diagnosis, and there's a specific tool to identify concussion in children and adolescents, which can be used by anyone pitch side. There's a pocket recognition tool, and this is just an example of the SCAT5. I think we're up to SCAT6 after the recent Paris conference, but it hasn't yet been updated. Lots of things that look like concussion but aren't concussion can occur. I'll just show this video very quickly. So there's the Ashes a number of years ago, and player, Australian batsman, hit there. He kind of didn't feel brilliant immediately afterwards, but carried on playing, and then actually scored a century, fielded for the rest of the day, came back into bat the next morning, and swiveled round to hit a bouncer and became acutely very dizzy and vertiginous and collapsed to the ground, didn't lose consciousness, was rushed to hospital. There were great concerns that something terrible had happened, and then had scans and was fine, and was brought to me, asking whether he could play because if he'd had a concussion, he would have to have a period of time out. And in fact, he had a positive Hall-Pike's test and had benign paroxysmal positional vertigo, an inner ear problem. Now, he may well have had some degree of brain injury as well, but there was absolutely nothing to suggest that clinically. And with treatment of positional maneuver, Epley's maneuver, his symptoms completely resolved. So that was symptoms following a head injury that were not due to brain injury. This is another scan of a rugby player who was tackled and developed some problems with speaking and swallowing for a couple of seconds afterwards. He then was given a diagnosis, removed from play, given a diagnosis of concussion, and became extremely dizzy in the car home and was vomiting, was taken to A&E, had a normal CT head, went to bed, woke up the next morning, had a shower, and couldn't feel the hot water on one side of his face and body, looked in the mirror, and one of his eyelids was droopy. So I was called and arranged for an urgent MRI scan. And you can see here, this is an angiogram, an MR angiogram of his neck arteries, and you can see the vertebral artery on the right there is present and it's absent on the left. And he had a vertebral artery dissection and a brainstem stroke from that, which is obviously needs completely different management to a mild traumatic brain injury. This is fortifications in medieval Belgium towns, and this is to remind me that fortification spectra or visual aura that precedes migraine can be triggered by head knocks, and we've got a steady stream of people that are diagnosed with recurrent concussions from innocuous head injuries, but in fact they're having trauma-triggered migraine with aura, which can be managed quite easily with prophylactic medication and isn't really a major concern. And just finally, this is a young, I think he was a 15-year-old, who every time he played rugby seemed to get knocked out for no apparent reason, very, very minor injuries. And he had arrested hydrocephalus, and it turns out that this had probably been from birth, but required surgical intervention and probably not playing rugby again. So there's a lot of mimics of concussion. So what about the role of rest? Well, there is some evidence that abstinence in the first 48 hours from screens reduces symptom duration, but there's also pretty good evidence that rapid return to normal activities also reduces screen symptom duration. So what we tend to suggest is try and have pretty much complete rest for the first 48 hours after a concussion, and then really rapidly try and get back to normal activities, even if there are some mild symptoms. And in adolescents and children, normal activities tends to mean education. So education trumps sport, and I really recommend people try and get back to being able to go to school, being able to use computers and write essays and read books before concentrating on return to sport, even however keen athletes they are. So what about the rehabilitation? Well, there's this thing called the graduated return to play. And this is an example from football. And essentially, there are different return to plays for different age groups. At the bottom, you've got an under 19. And it consists of an initial rest period followed by increasing stages of exercise according to symptoms. And if people develop symptoms during one of the stages, they go back a stage. And the idea is that people can go, the symptoms drive the return, and when they're symptom free and have gone through all the stages, they can return to full contact. There are a number of issues around the return to play, so its effectiveness is not really clear. It's an incredibly generic pathway for a heterogeneous group. So as I'm going to show you in a moment, people can have all sorts of symptoms following head impacts, and this just lumps them all together. There are no objective measures of recovery. We're dependent on people's self-reporting, and no symptoms doesn't necessarily mean complete recovery of the brain. There's a need for a return to study protocol in adolescents, which doesn't really exist. We just kind of make it up on the fly. And at the moment, the return to play protocols are sport specific, but as we all know, many adolescents play multiple sports. And I've got a number of patients in the clinic that had a concussion playing rugby, but were playing basketball 2 days later, as their coach had no idea that they'd had a concussion, and they didn't really realize that they shouldn't be doing that. So what happens after concussion? Well, this is a study of post-injury recovery in high school and college athletes in the US. And essentially, the vast majority of people recover pretty quickly. So within 7 days, 85% of people in this study had recovered. I think that's a little bit high in my experience. But then there's a group of people that take longer. And that, in different studies, that ranges of anything from 5 to 30%. And there's a smaller group that take up to, that have persistent symptoms over a month. Again, depending on the study and the population, it's probably around 10 to 15% rather than 3% in this study. So this is an example of an adolescent with prolonged recovery. And the key message here is that people have multiple symptoms and there are multiple causes. The concept of post-concussion syndrome needs to be consigned to the dustbin. it's almost entirely useless in my experience, and it's much more useful to try and get to the bottom of the cause of symptoms in individuals. So this is a case of a 16-year-old rugby player who had a head injury with no loss of consciousness and no other objective markers of severe traumatic brain injury. And I saw him a few months later where he was still very, very disabled by symptoms. He had significant cognitive complaints of poor concentration and poor memory. He had headaches, fatigue, imbalance, visual vertigo, which is an experience of vertigo in visually busy environments, marked anxiety, and really unable to tolerate exercise. And he was, his GCSEs were just about to start, and he was really struggling and unable to revise and probably sit his exams. So the key here is that there are multiple systems around the head and neck, and these are all listed here. And the trouble is that damage to these systems causes a very generic set of symptoms. So we've got headache, fatigue, brain fog, dizziness, problems with cognition and mood, problems with sleep and balance. And the symptoms themselves don't really map on that well to the damage to the systems unless you go into more detail. So with this guy taking a better history, his headaches were clearly migrainous. And we know that migrainous headaches can occur after head impacts, and they're really treatable, but they need specific treatment. His examination of the vestibular system was clearly abnormal, so he also had vestibular dysfunction. His brain scan was normal, which was incredibly reassuring for him as he was convinced he had severe brain damage. His neuropsychological cognitive profile just showed problems with attention. So we know that attention can be impacted by somatic symptoms, by mood. It is not necessarily a marker of organic brain damage. He had really severe low mood and anxiety, and that was really driving a lot of his other problems. He could tolerate exercise if he kept his heart rate low and didn't move his head. So he had some autonomic disturbance, and presumably minimal head movement didn't upset his vestibular system. So all of these issues can be treated, a migraine with medication, vestibular physiotherapy, low mood and anxiety with cognitive behavioral therapy and medication, and increasing exercise tolerance to help with autonomic dysfunction. So the key to diagnosis is correct diagnosis leading to appropriate treatment. And this pattern I see again and again. What about multiple concussions? Well, there's limited evidence regarding management. There's some evidence that more may lead to more and treatment-resistant symptoms. There's no magic number. If you've had X concussions, you should stop all contact sport. Generally, if people have more than 2 in a year, we consider a prolonged period without contact, although this isn't evidence-based. And we've already discussed there is concern about long-term effects. But whether this is a concern in young people who don't go on to continue playing contact sports or not is currently unknown. So there's some evidence, there's some work done on prevention. First thing is education. People should report symptoms and take time to recover. Rugby is just about to introduce very wide-ranging changes to rules in the height of tackle. And there's some evidence that warming up in schoolboy rugby players reduces concussion risk. There's also some evidence in adults that neck strength is important, but that's yet to be replicated in adolescents. So the clinic at ISEH, the Complex Concussion Clinic, we've seen more than 1,000 athletes in the last 6 years, lots of rugby players, but many other sports. The referral reasons, mainly chronic symptoms, delayed return to play, and all players are assessed by a neurologist. If they're under 16, by a sports medicine consultant. Many require vestibular assessment by our dedicated vestibular physiotherapist. About half have advanced brain imaging. Very few require neuropsychological assessment, and the vast majority return to normal activities with correct treatment. So in conclusion, sports-related concussion is really a significant problem at all levels in sport, but presents particular problems in adolescence due to problems around schooling, and multiple sports and difficulties with symptom descriptions. It's difficult to delineate the extent of any brain injury in acute presentation, so all should be managed as if they are potentially severe. If people have ongoing symptoms, the cause of the symptoms needs to be diagnosed and not just labeled as post-concussion syndrome. In my experience, psychological factors become more prominent over time, so symptoms really need to be managed early to avoid development of psychological comorbidity, which really complicates recovery. And there is some evidence that adolescents are at higher risk of complicated concussions with prolonged symptoms, and they can be more difficult to manage for a whole host of reasons that are not just the case in concussions, but the case with that population, their parents, their schools, and some of the complexities there. There's the email for the concussion service, and we're more than happy to see anyone or give advice around any issues relating to head injury in sport. Thank you.
Thank you very much to Dr. Sylvester for sharing your far-sighted understanding of how to manage the multiple problems that we see after head injuries. There are some questions gathering for you. So as I understand it, if you don't get the diagnosis of these problems right, you can't get the treatment right. Patients aren't always good historians when it comes to neurology either, so it can make it even more difficult. So we had a talk previously from Dr. Amal on the female development and how that affects adolescent injuries, and consisting the multi-systemic effect that REDS has. Can this make the population of adolescents more vulnerable to concussion severity in females and males? Because you do see and relative energy deficiency in males as well.
I suppose the answer to that is I don't think we know. There's certainly there's a metabolic abnormality with brain injury, and it's characterized by a high metabolic state in the brain. So in theory, relative energy deficit could worsen that. And certainly some of the treatments we use after brain injury, and especially in some post-traumatic migraine, are things that make mitochondria work better, like coenzyme Q10, for example. So, I mean, the answer is possibly, not sure. But I think our understanding of the risk factors in individuals for concussion and prolonged problems is evolving all the time.
How can clinicians diagnose and manage concussion in the setting of the recent COVID-19 infections, where we've all seen a lot of neurological and fatigue symptoms?
So, I mean, well, I think you mean kind of prolonged concussion symptoms. Acutely, it's not easy to diagnose. Actually, it's very difficult because we don't have particularly good objective ways of diagnosing brain injury. But I suppose the prolonged symptoms that people can get after a mild traumatic brain injury are very similar to those we've seen with chronic fatigue syndrome, with long COVID. In fact, I recently reviewed a paper where people argued that the treatment for long COVID should parallel the treatment for prolonged concussion symptoms. And I think that's probably right. I think the mechanisms probably share some common features, and there's probably chronic inflammation in a subset of these people. I think the brain has very limited responses to chronic inflammation and chronic unhappiness, and they come out as fatigue, kind of brain fog, headache, poor sleep, psychological problems. I think the real difficulty, and really what I try and do in the clinic is rather than saying this person has a syndrome, say, look, we know that the vast majority of people after a head injury sustained in sport get better really pretty quickly. What's going on in this individual? Why haven't they got better? Is it physical issues such as development of migraine or vestibular dysfunction? Or is it something else like psychological factors? Or in fact, is it complete misattribution? I've seen lots of people where it's absolutely nothing to do with the head injury they've sustained. And people are always looking for something to hold on to. And I've made all sorts of, medical, neurological, psychiatric diagnoses in people that have been concerned they've had a brain injury. So it's quite difficult, but rewarding.
Fantastic. What should coaches do now? I know you're talking more about the sort of longer term effects, but what about the shorter term effects that brain injury has, and what should coaches and parents do in the immediate and first 24 hours after a suspected concussion in a child? People are worrying that it's very hard to get access to a GP now.
Yeah, I think it's very hard to get access to a GP within the first 24 hours. I suppose that there's kind of two bits to it. So one is identifying the kind of high risk group that probably need to go to A&E and might well need acute imaging. So I think people that have significant loss of consciousness, more than a second or two, significant confusion and post-traumatic amnesia. We think that post-traumatic amnesia is probably one of the best markers of traumatic brain injury. So this is where people after the event can't form new memories. So for instance, I'll go on my round and see someone who's had a brain injury in the hospital, go and say hello to them, spend ages going through their scan, go out and get a coffee, come back and say hello, and they're like, oh great, never met you before. What can I do for you? And that's post-traumatic amnesia, an inability to form new memories. And that happens pretty commonly after concussion, but it's very short lasting, half an hour. So people that remain confused and can't form new memories for more than an hour, persistent vomiting, drowsiness, they need to go to A&E and be assessed. I think once you've kind of you're not too worried about people, they need to be somewhere where they can be observed just in case they deteriorate. As I said in the talk, there is actually pretty good evidence that avoiding screen use in the first 24 hours is good, and people just generally should rest. They often feel pretty awful and just want to go to bed. And then actually now we used to, before I was involved in the whole concussion thing, there was this kind of thing about resting for weeks and weeks and not doing anything. And the evidence is that's nonsense. You should get people back to trying to do normal activities as soon as possible in a graded manner. And obviously the key is to avoid contact where you're at risk of further head injuries until people have fully recovered, at least clinically.
Thank you very much. I think that we've run out of time. We've run over a little bit, but thank you very much for your talk. It's been very interesting, and I've learned a lot just listening to you speak. Thank you.
Okay, you're welcome.
So it's been a privilege for me, I know, to listen to such a wealth of multi-specialist knowledge from this group of ISEH experts, and in a very exciting and growing field of adolescent health in support of youth development. I'd like to extend thanks to everyone involved in putting together this 2023 ISEH webinar on adolescent health, including, of course, the speakers, the organisers, the audiovisual team, ISEH and HCA media team, and of course, all of you for attending. Here's to a healthy year ahead for you and your patients. And if you have any concerns with a child's growth, development, or injuries, please do get in touch with the ISEH team to speak to one of our doctors. If you need any help, do reach out. We are here to help. Thank you.